Actually, the first slide was the day the president was launching this Scorecard Hub, an online platform dedicated for health. It is built for countries. It is a public directorate where countries highlight best practices. There are online courses, there are guides and toolkits to help countries create, analyze, and improve their tools. We have events and webinars. There is an exchange of information, and also technical support for ministries of health to request help and guidance with the scorecard tools. And what is interesting is the number of countries that are now sharing this information. As you can see, those are flags of the countries that are sharing information on that. You can see what is happening in Ghana, you can see what is happening in Rwanda, and if there are good practices, then countries can contact each other and start sharing that and learn from each other. And so far, over 110 scorecards have been shared from 9 countries in the areas of malaria, reproductive health, nutrition, and community health. 30 best practices from 27 countries, including case studies, video demonstration, and short policy briefs, have already been published on that digital hub. Now, when it comes to End Malaria Council, and the plan to have 15 councils by end of 2021, there's a lot of progress. We now have 6 countries that have operational End Malaria Council, including our own country. You see there, Cabinet Secretary Mutahi Kagwe at the launch of Kenya's End Malaria Council in February this year. We have about 10 countries that are an advanced planning stage or designing to have their particular councils. Let me say that this varies from one country to another. In Kenya, we chose to take the path of private sector led so that we tap into them, but working closely with the public sector, but with a focus to the communities. In other countries, they are led by the public sector. In others, it's a mixture. But as you can see in the last few months, Cameroon, South Africa, and Burkina Faso have all launched their End Malaria Councils. Now, let me share a little bit about some of what the End Malaria Councils have been able to do. Let me move here and read this a bit small. In Eswatini, for example, the councils, which are really locally driven, have been able to address issues of stockouts. They have also been able to raise funds to pay salaries for people that support indoor residual spraying, and they have been able to have sensitization meetings through use of celebrities like Yvonne Chaka Chaka. In Zambia, they have mobilized over 500,000 USD from the private sector to fund mass drug administration in priority district, looking towards pre-elimination. They have been partnering with influential organizations, including the Zambia Football Association. They actually also partner with their revenue authority to support malaria control efforts. In Mozambique, they have mobilized commitments, more than 3.5 million USD, to close the gaps in the malaria strategic plan, as identified there. Uganda, they have organized a national communication campaign to raise the visibility and mobilizing financial and in-kind to provide preventive treatment in high burden. In Kenya, as I mentioned, the council was launched in early this year. I'm happy to say that now the legal process, it may not have taken, it took a little bit of time, but in the last 3 weeks, it now has the legal registration to be able to now start fundraising. And you are going to see and hear a lot of it in the coming few days. And part of what it's planning to do is to have a private sector engagement in preventive measures. The council, which I'm the secretary, is developing a national resource mobilization strategy and advocacy plan. And the advocacy, and especially community communication at community level, supporting DNMP, the malaria program, to pass messages at that level.
Eyesight is also failing me. Fellow colleagues, all protocols observed. Mine is very, very brief. I think today we've learned a lot about malaria, and it's exciting to note that the prevalence is coming down. It is really exciting because it tells us that the people who are going to die from malaria and are dying from malaria is decreasing. And if you look at the health policy in Kenya, by 2030, one of the first objectives of the health policy in Kenya is elimination of communicable disease, and malaria happens to be one of them. Last year in 2020, the country tested a total of 11 million people or tests, and 4.1 turned out to be positive. But the most important thing is that the numbers are going down. And also, malaria is no longer the leading cause of outpatient visits in Kenya. It's now number 2 after respiratory diseases. These are good news, good Kenyans. And the fact that the indicator survey is showing us that the prevalence has come down to 6%. I think if we pull together, if we walk this path together, we shall be able to push the level of malaria even further down, and by so doing, relieve Kenyans of the burden of suffering from malaria and suffering from any other disease that may be related to malaria, including anemia, loss of pregnancy, and so many other things. The path that the Kenya has taken, this country called Kenya, is clearly demonstrating that the results are coming out. And I think the team led by Dr. Githuka deserves a hearty clap. And without much ado, we recognize the fact that this cannot be done by the government alone. It's a sector approach. And for us to be able to go far, we are informed that we must work together. But if you want to work fast, you do it alone. But this country has taken the strategy of working with others. So you'll allow me to invite the representative from USAID to come and make a few remarks, because
all protocols observed. I would like to say that it's great on behalf of the US government to be here, and just basically as a demonstration of a strong strategic partnership that the US government through a presidential malaria initiative that is being implemented by USAID, CDC, and the US Department of Defense. So we are truly happy to be here, just to see the results that are being presented. It will allow me to take some time to just highlight for you some of the key points that I'm expected to speak on behalf of the US government. So we would like to take this opportunity really to congratulate Kenya for the great progress that we have, my voice can be, that we've made in curbing malaria. The new survey, the KMIS, surely does demonstrate that we are making very, very good progress. We're on track to end malaria, if only we were to come together as we've done in the past. We are seeing that overall, the prevalence of malaria is down now at 6%. The US government, through very strong strategic partnership with the Kenya government and other key stakeholders, are determined and continue to be committed to eliminate malaria by 2030. We are aware that in some counties within the country, we are already within the reach of eliminating malaria. While in some 19 counties, within malaria is completely under control. But in other counties, we are still facing some challenges. And for US government, in partnership with the Kenya government and other stakeholders, these are the areas that we are going to continue to target with both resources, technical assistance, involving private sector and all other players to make sure that we achieve the vision that our president has set for us to end malaria by 2030. The US government has supported a variety of malaria intervention, ranging from prevention, diagnosis, and treatment, through the Presidential Malaria Initiative. And we know that for sure that initiative is currently being implemented by USAID and CDC. And that partnership really continues to demonstrate great strides, great results for the country. Since 2006, the US government, through Presidential Malaria Initiative, has invested a total of about 50 billion Kenya shillings. We have helped to distribute about 20 million insecticide-treated nets. We have protected more than 20 people through IRS, that's indoor residual spraying. We have delivered more than millions of malaria rapid tests and fast-acting medicines. But besides that, besides just the ITNs, the spraying, and the treatment, the US government, through CDC and the US Department of Defense, the Walter Reed, continues to invest in research and evaluation of various tools that will help us curb malaria and achieve the goal of eliminating malaria by 2030. One key example of that is the vaccine that has just been validated and or cleared recommendation by WHO. The trials for this were actually done here in Kenya, in Western Kenya. And we are so proud with the work that Cambridge and other stakeholders are doing in Western Kenya to put Kenya at the global map of trying to end the malaria. And the fight to eliminate malaria continues, and we are determined that that will end. As US government, through CDC, USAID, and US Department, we are very happy to present the survey today because we know we're part of funding it. And through Global Fund to fight AIDS, TB, and malaria. We believe that success can only be achieved if we have policies and strategic programs or interventions that are informed by evidence. The KMIS is one of such key sources of data that will help us evaluate the policies and develop new ones and drop those ones that are not working, and also to readapt our implementation strategies so that we can be able to achieve very good results and continue to eliminate malaria by 2030. We'd like to pause and basically thank really, very sincerely, about 8,000 people that, despite the challenges and the fear around COVID, took part in this survey and made it possible for us today to present the results that we are talking about today. So we can't take that for granted. So really, I think for USAID, CDC, and US Department of Defense, we believe in strong strategic partnerships. And it's only through this that we know that we actually eliminate malaria by 2030. We know for sure that, as the survey indicates, that there's an overall decline in prevalence, but the endemic regions within the country still have challenges with this. For US government, in partnership with the Prevention of Malaria and other stakeholders like WHO, we believe that this terrible disease will ultimately be defeated only if we join hands together. In this fight, we don't want to let, just as Dr. Kwela has told us, to let or leave private sector behind. We know they have a role to play. And for US government, USAID, CDC, and US Department of Defense, we are taking very strong and deliberate steps to work very closely with the private sector. And we know that if they start manufacturing some of this, the medication and even the test kits, for sure we'll be having a sustainable response to fighting malaria in the country. But not just that. We believe that communities, local organizations are also key in the fight against malaria. And therefore, our work together with them, investing in their capacity, building their capacity, we believe will help us fight this. We are very happy with the Kenya government for the launching of the Kenya Malaria Youth Army by the President. Again, we know that youth has a key role to play in other development areas, but more so in the malaria prevention. The youth are key to our investments, and we'll continue working with them to end the malaria. As the saying goes, if you want to go far, fast, go alone, but if you want to go far, then work together. That is the strategic partnership that USAID, CDC, and the US Department of Defense is keen on, and would like to make sure that we expand it, we sustain it, and until we achieve the vision of ending malaria by 2030. We thank you, and we really, truly appreciative of the leadership that the President has shown through his being part of Untitled Malaria. And the US government would like to assure him and other all players that are helping work on malaria of our continued commitment, support, in ending malaria. Thank you very much, and looking forward to working with you.
What we call intermittent preventive treatment in pregnancy, where we give pregnant mothers from the malaria endemic, living in the malaria endemic zones, the lake endemic and the coast endemic, we give them Fancida or sulfadoxine pyrimethamine once a month from just about the end of the first trimester, and it is recommended that they get that dose, usually a directly observed therapy where they take in the clinic as they observed, monthly until delivery to be able to protect them against malaria. As I had said earlier, pregnant women are most vulnerable to adverse outcomes of malaria. Malaria is a leading cause of loss of pregnancy, early and late. It's a leading cause of premature delivery, leading cause of even maternal mortality, because the malaria parasite affects our red blood cells that carry oxygen to our organs. So when mothers have malaria, their blood levels go low, and when they deliver, even if they bleed a bit, which is usually normal, it may lead to maternal mortality. So malaria. And as I said, the Fancida is recommended. They take 1 dose every month, and a minimum of 3 doses, at least 3 doses or more, depending on when they start. So overall in the country, 38% of women had taken at least 1 dose of SP for prevention of malaria in pregnancy. 2 doses dropped to 30%, and 3 doses dropped to 22%. And these are the trends that we see. In 2015, at least 53% of women had taken 1 dose of Fancida to prevent them against malaria in pregnancy. This dropped to 38%. In 2020, in 2015, again, 36% of women had taken at least 1 dose of Fancida, dropped to 30%. And the third dose remained more or less stagnant at 23%. However, as I had highlighted earlier, this Fancida or this medication to prevent malaria in pregnancy is not given throughout the country. And these slides were giving the data for the entire country. We normally recommend them to be given at the malaria endemic regions, the lake endemic region and the coast endemic. And here we can actually see that there was an improvement in the uptake of Fancida to prevent malaria in pregnancy. At least 1 dose, it rose from 77% in 2015 to 80%. At least 2 doses, it rose from 56% in 2015 to 65% in 2020. And the third dose rose from 38% to 48%, which is quite encouraging because these are the mothers who are at most risk of getting malaria, the ones living in the malaria endemic regions of this country. So the key findings from malaria prevention interventions that we assessed, at least 1 in every 2 households in Kenya have 1 ITN, 1 insecticide-treated mosquito net. And 40% of the household population, that now goes specifically to people who sleep under a mosquito net, have access to an ITN. 35% of household members, 42% of children under 5, and 40% of pregnant women in the country slept under an ITN the night before the survey. And 22% of women in the country, again, took at least 1 dose of Fancida, took at least 3 doses of Fancida to protect them against malaria in pregnancy. I will zero in again on malaria in children. I think second, or equally as pregnant women, children are most vulnerable to getting severe malaria once they get malaria. And so it is also important that we are able to assess how this is managed once they get malaria. So assessing malaria in children is an indicator of how well malaria is managed or treated in this country. So we look at the case management in children, we look at the proportion of children who had anemia. As I said, malaria causes anemia, and the prevalence of malaria overall. So normally we recommend that when you have signs and symptoms of malaria, that is like fever, headache, joint aches, that you visit a health facility, get properly diagnosed and treated. And so during the survey, we asked the mothers of the children that in the 2 weeks preceding the survey, of the children who had any signs and symptoms of malaria, whether they sought treatment. And we saw that the answer was that 68% of them sought treatment from public health facilities. That's slightly over 2/3. And 32% sought treatment or advice from private medical sector. The private medical sector is broad. It's all the way from private clinics, private health facilities, chemists, pharmacies, etc. And it is recommended, even when you go there, you should first be tested for malaria before you are put on treatment. So, again, when we asked the mothers of children under 5 that after the children were diagnosed with malaria or were thought to have malaria, what treatment did they take? And 91% took an ACT. ACT is what is recommended in this country for treatment of malaria. It's a artemisinin combination therapy. It's use of more than one drug to treat malaria. And malaria parasites are sensitive to this. So this is an encouraging result that at least over 91% took the correct medication for malaria when it was either diagnosed or thought to be malaria. The others are the drugs that have been used previously for treatment of malaria, like chloroquine, where there is resistance. There is a testosterone injection that is mostly used for treating severe malaria, amongst other treatments that are usually not recommended for management or for treatment of uncomplicated malaria. When we look at trends, when we compare between 2015 and 2020, we compared the results. In 2015, 72% of children under 5 who had fever in the 2 weeks preceding the survey sought treatment or advice. This dropped to 64% in 2020, so a decline of 8%. And then we asked, as we said, you need to be diagnosed for malaria before you are treated. And this usually through a malaria rapid diagnostic test kit or through microscopy. So we will require to either have a finger prick or a heel prick amongst children who are very young. So we asked amongst them how many were diagnosed, how many were tested for malaria. And in 2015, 39% were tested for malaria, and this dropped slightly to 36%. At least the use of ACT remained constant at between 92 and 91%. Again, people will ask, why did the issue of seeking treatment drop from 72% to 64%? Why did the issue of being tested before treated drop from 39 to 36%? But we can remember that during the implementation of this survey is when there was still the COVID pandemic, when people were afraid to visit health facilities because they felt that if you are diagnosed or if you have fever, you might, for example, be put under isolation or quarantine. But we are digging deeper to find out why that is the drop. What were the knowledge, attitudes, and practices that were affected, especially in health-seeking behavior? We shall look in the second issue of anemia. Malaria is a leading cause of anemia, particularly amongst pregnant women and children. As I said, it attacks the red blood cells, which are the ones who transport oxygen to our organs. So the prevalence of anemia in children aged 6 months to 14 years, and this was defined as a hemoglobin of less than 8 grams per deciliter, again was highest in the lake endemic region, where the malaria burden is highest, and seasonal transmission regions, where it was 3%. In the coast endemic, it was 2%. In the highland epidemic prone, 1%. And in the other low-risk counties, less than 1%. However, I would say that malaria is not the only cause of anemia, but it's actually a leading cause. So there could be other confounders, but it's usually a good indicator to see the severity of malaria. We shall now go into the prevalence of malaria. And the prevalence, we tested children for between 6 months and 14 years using both malaria rapid diagnostic test kit and microscopy. At this point, I'd like to highlight that microscopy is the gold standard for testing for malaria. So we use the microscopy results to be able to determine the prevalence of malaria in this country. The test kits are usually slightly, more sensitive, but when you do microscopy, you actually see the malaria parasites. As you can see from that graph, and we shall go with the brown one.
Now, when it comes to regional economic community engagement, as I've said, the President endorsed the appointment of our 2 special ambassadors, working closely with all the economic blocs. And you can see there, those are the economic blocs. We have now signed a memorandum of understanding with all of them, the IGAD, the SADC, the West African ECCA, and IGAD as well. And one of the areas that we've made progress is that between the East African community and the Democratic Republic of Congo, which, as you know, is a major source of malaria, the highest burden, maybe the second after Nigeria in Africa. And because malaria knows no boundaries, we have come with this initiative where we want to address malaria within the border areas of all the countries of East African community and the Democratic Republic of Congo, a 5-year plan that will ensure that we harmonize the responses across the borders of the countries that form both blocs. The issue of the youth army in July this year. First, earlier in the year, there is Alma Youth Army that guides the formation of youth across the continent. The idea being that the youth must be in the forefront. They need to participate in international fora at the African Union and globally to really press for malaria to remain a high priority. And here in Kenya, we launched the Youth Army in July this year, and I'll tell you what plans we have for them. So, what are some of the priorities here in Kenya to ensure that the President's legacy agenda is sustained? And I'm going to go through some 6 priorities. I've talked about the End Malaria Council. Its main work will be resource mobilization, domestic resource mobilization, to ensure we close the gap that we have in the implementation of the strategy. I know the plans are there, and already a lot of interest has come from partners to start contributing in this support to the council. And the idea is that the council does not replace the malaria program. These are busy business leaders. They will work and see how best to support, especially using scorecards, seeing where the challenges are and putting the money where the need is. The second one is innovation. And as you can see, we want to focus on prevention. And the issue of larviciding and indoor residual spraying is going to be very key. We want to deploy the technology. You can see there use of drones in Kilifi earlier in this year that was presided by His Excellency the President. So we are going to deploy this in a number of counties that have large breeding sites, like in Kisumu, Kilifi, and Kirinyaga. Then the other area, innovation, is rapid diagnostic test kit. With all the knowledge and expertise within our institutions of research, Cambridge has actually produced a malaria rapid test kit that was unveiled by the President in July this year. It is undergoing validation. It is scheduled to be launched in December, slightly over a month from now. It's just now undergoing validation. So that will be a big plus for us. Scorecards, we actually want to continue strengthening them so that they are used for advocacy, resource mobilization, and program improvement. We want to see this as really helping to improve program. And then we are keen to implement scorecards for NTDs and really go down to communities, as I said. For the Youth Army, His Excellency the President has directed that the youth involved in malaria activities in country be incorporated in the Kazi Mtaani initiative. And we are therefore going to enlist 3,400 youths from 16 counties with a high burden of malaria into the Kazi Mtaani initiative that is coordinated by the Department of Housing. So these are youths that are now going to get a stipend every month, and they are going to dedicate their time on a daily basis to support malaria control efforts across the country. So we will be coming back to you because we'll need to capacity build them, we'll need to equip them, but for the very first time, we have a complete army dedicated to fight malaria in this country, an army with a lot of energy, the youths. Now then finally, local manufacture, we are working, the End Malaria Council is actually bringing a lot of private sector players on board to look at how we really must start manufacturing the bed nets, the malaria medicines, insecticides and repellents and larvicide in this country. Looking at the bottlenecks, we believe that this is not only going to help the efforts on malaria control, but create employment. So let me thank everyone, and let me really thank the people who have given us the results today. It goes a long way to analyze data, plan for such surveys. It's not easy. I understand. I've been there before. So I appreciate them, and then finally appreciate everybody working in the malaria control efforts, and I assure you that the President in his current role as the chair is very supportive of malaria control efforts. He wants us to really go to the communities, as you can see him here, taking his time to actually control a drone and do larviciding. This was in July this year. Thank you.
I'm so pleased to be here and really to listening to the good work done and the progress made, the control of malaria in this country. And this event marks a great milestone for the country. The country's response to malaria, which is a big public health problem affecting vulnerable people, we really value evidence. And it's good to see the data from the malaria indicator survey, the scorecard from at the national and county level, because we really advocate for use of evidence in planning and decision making. Ladies and gentlemen, the World Health Organization recognizes that countries, including Kenya, have made significant strides in the fight against malaria, and we've just witnessed that from the results that have been presented to us this morning. And on this, we appreciate efforts made by the leadership of this country, the government of Kenya at the different levels, the National Malaria Control Program, to achieve important objectives articulated in the country's National Malaria Strategy, 2019 to 2023. The WHO's updated Global Technical Strategy for Malaria clearly advises that country ownership and stewardship is critical for an appropriate response. And again, advises the evidence-based approaches to be able to tailor appropriate malaria intervention mix to ensure targeted and optimal malaria response. Indeed, today marks that day for Kenya that has shown that stewardship that has resulted in the generation of strategic evidence and data for use in the fight against malaria. We've appreciated this morning, and of course the progress reports that have been shared and the annual reports, and of course the scorecard at the different levels of the system. Ladies and gentlemen, malaria remains a big problem, and globally in the year 2019, we registered over 200 million cases and over 400,000 deaths, and 94% of these were in sub-Saharan Africa, Kenya inclusive. And what does this mean for us? We need to work harder. We need to reinvigorate our efforts, mobilize more funding streams, and support all aspects of the National Malaria Strategic Plan to enable acceleration of efforts towards malaria elimination. We are all pleased to see the progress and reduction in prevalence, uptake of interventions, but I think we need to again remember that moving from where we are to take it to the end will be even harder. We need innovation, we need commitment, we need more resources. We are lucky in that we have the strong commitment of the head of state himself. And I think that is a very good contribution to the efforts. Ladies and gentlemen, join me in congratulating Kenya for the tremendous achievement made in the fight against malaria. Again, we appreciate the strong leadership on the different fronts to accelerate efforts towards malaria elimination as per the resolution of the 74th World Health Assembly, the resolution of the 74th World Health Assembly. WHO lauds the establishment of the End Malaria Council and Fund to mobilize resources for elimination of malaria in Kenya and the launching of the Zero Malaria Starts With Me campaign by the head of state, Excellency Uhuru Kenyatta, and all partners who are here, who have supported initiatives. And some of these initiatives have helped us to mobilize resources from the Global Fund. I want to reiterate the commitment of the World Health Organization, ladies and gentlemen, that will continue to support strengthening of leadership and coordination on critical interventions for impact. We will support country efforts at the generation and use of strategic information for decision making, including research. We will provide technical assistance, build institutional capacity, we will strengthen partnerships, we will support resource mobilization efforts to ensure integrated implementation of the Global Technical Strategy for Malaria and the Global Vector Control Response Plan and the Global NTD Roadmap. Again, I want to congratulate Kenya and all malaria partners for all these achievements, but also again to remind that we have even a bigger challenge ahead of us as we move towards elimination. Thank you so much.
About what ALMA is doing, Dr. Giduka, my colleagues, Dr. Ganatra, senior MOH officials, we have other arms of the government here, Kenya National Bureau of Statistics, the director is here with us, Dr. Awes, also who has been with us. Yes, I know Dr. Obodo is here. Representatives from the donors and partners, USAID, and I'll be naming them shortly, WHO, and who else?
Okay, thank you very much for the question. When we talk of improved sources, usually we look at various sources. We have, for example, like spring, or water from spring. We have wells which are covered, also the boreholes which are covered. Those are called, are referred to as improved sources of water. The sanitation, again, we have different types. We have like those improves, what do you call, latrines. We have the flush. Those are some of the improved types of sanitation.
Good morning. I think as I've been introduced, my name is Dr. Giduka George, the head of the Division of National Malaria Program at the Ministry of Health. And I will take us through the key findings from the Malaria Indicator Survey that, as we've been informed, was done between November and December last year. My first presentation will be on malaria prevention. And as a Ministry of Health, we do implement many prevention interventions for malaria. But for this survey, we looked into these two, the issue of insecticide-treated nets and prevention of malaria in pregnancy. And I will start with presenting on the insecticide-treated nets ownership. Overall, in the country, there was a 49% ownership of nets, of which in the rural areas, the ownership was slightly higher at 52% versus 44% in the urban areas. And we'll be able to see why that is in other slides to come. Number two, we normally do regard ownership of mosquito nets. When we say that a household has one mosquito net for every 2 people, we call that universal coverage, meaning that those nets should be enough for everyone to be able to sleep under them. And overall, 29% of households had at least one net for 2 people, of which, again, marginally higher in rural areas at 29% versus urban areas at 28%. The distribution of net ownership in the country, as has been presented earlier, malaria is not evenly distributed in this country. There are areas that are the highest burden counties. The counties along Lake Victoria, what we call the lake endemic counties. And in those counties, the net ownership, at least having at least one ITN, 78% of households had at least one ITN, which is quite high compared to the other areas, but also the burden for malaria is highest there. The coast endemic region, again, had around 58%. 58% of households had at least one ITN. The highland epidemic prone at 65% of households having at least one ITN. The seasonal transmission areas, 35%. In the low-risk areas, which is where we are, in Nairobi, the central region, the number of proportion of households that are at least one net was 31%. The trends in net ownership, all the way from the year 2010. In 2010, the households that had at least one mosquito net was at 48%. This rose to 59% in 2014, 63% in 2015, and 49% in 2020. So we can see a drop in that, and I should be able to explain that. And the nets, and the households that had at least one net for every 2 household members, again rose from 35% in 2014 to 40% in 2015, and again dropped to 29%. Because I know this will elicit a question, normally when we have been doing the other malaria indicator surveys, for example, the previous one in 2015, we had just conducted a mass net campaign in some of the counties, and the campaign was also ongoing. Due to COVID, the mass net campaign that we had planned to do earlier last year was postponed to this year to be able to comply with the COVID-19 containment measures. We did not want to distribute nets and also, contribute to the spread of COVID-19. So this could explain why there is low net ownership this year. And also, secondly, is that we normally do another survey after we finish the mass net campaign to see whether the net ownership has increased, and this should be done as soon as the mass net campaign that is ongoing is concluded. When, again, we ask the households, what were the sources of their nets? We can see quite a huge proportion, 53% was for the mass net campaigns that we do every 3 years. This is distribution of free mosquito nets to counties where malaria transmission happens. Also to note is that 16% of the nets that were found in households were from ANC clinics. Again, in counties where malaria transmission happens, we do give pregnant mothers a mosquito net when they come for their antenatal clinic to protect them against malaria, because as we all know that pregnant women are most vulnerable to adverse outcomes from malaria. The other sources of nets were from purchasing from shops and markets, 21%, and other sources, which were many, were around 10%. So overall, we can see over 2 of every 3 nets that are owned in this country have been distributed from our public health system by the Ministry of Health. Now, we asked the households that had at least one mosquito net or more whether they were using the nets. You will know it's one thing to have the mosquito net, it's another thing to sleep under it. And of all the households in the country, as we said, of the ownership, of the households, 40% had households, only 35% were using overally. In the urban areas, 39% of households who had nets, only 35% of them had slept under the ITN the night before the survey. And in rural areas, this dropped. Again, there was a gap between net ownership and net use. And that is one of the things that needs to be addressed as we distribute the mosquito nets within the community. Again, there are the trends of access and use of mosquito nets. We can see of the households that had a mosquito net, there was that gap between them having the mosquito net and them using it. And in the KMIS 2020, there was a 5% gap. And we can see, again, as we said, in 2020, there was a decline in both access and use of the mosquito nets. When we look at all the households, again, in the country, when we ask whether any household member had slept under a mosquito net the night before the survey, all households, which was 35% of them, slightly higher in children under 5 years old, which rose to 42%, and again dropped a bit to 40% amongst pregnant women.
Also the KNB website and also the KNBS website. And the data from this report is also going to be made available to the public launch. The KMIS report will be available, a good technical support in terms of data analysis, report writing, development. Lastly, I want to thank the field data collection teams for the good job that they did, and of course the community members, for healthcare workers who have continued.
I'm actually fully vaccinated, but if there is a third dose and I'm advised to go for it, I will. I'm McDonald Jojo Budo, the Director General at Kenya National Bureau of Statistics. So I'm here representing the organization that has been partnering with the Ministry of Health and all the key partners in this. I'm actually also doing so as a stakeholder in the sense that when you saw the presentation there is the region that has the highest prevalence of malaria. And that is the Lake region. Actually, while at home, we get our domestic water right from Lake Victoria. So that tells you why I'm representing my area also in this, because we are hard hit in Kenya. Well, the national prevalence is just 6%, our case is 19. So quite serious, but there is hope at the end of the day, because each time it has really been going down, and we appreciate that. So colleagues, all protocols observed, ladies and gentlemen, I would like to express my very interest in this, that today we are now launching a report that has taken a bit of time to compile. And it is actually at a time that the country requires a lot of data. COVID-19 has taught us a lesson that resources can really be very scarce. And so when we have any single coin, you really want to have it invested in an area that would give you the best results. And so when we have such kind of results, then we know, or we would know really what proportion of our resources can we inject in elements that deal with malaria.
and of course, the very, very particular interventions that would be useful to this nation. So the findings will actually go a long way in ensuring that this pandemic or endemic keeps on going down. Now, we have been partnering with the Ministry of Health, and of course, there are several other key players, among them being the USAID and the technical support that was given by ICF International, of course, courtesy of the USAID. And with that, it has really enabled this exercise to be a success. We have always partnered with the Ministry of Health, not only in malaria indicator survey, but several other studies that we have done over the years. But specifically about malaria indicator survey, this we started doing way back in 2007. Then we came to 2010, 2015, and now 2020. And all those series, I'm actually quite happy that I've been part of it. And each time, as we have seen, the trend is going down, which gives us great hope as a nation that the programs and interventions that are being put in place are actually bearing fruit. And that is a great thing to really appreciate about. Now, the Bureau, in terms of the support that we have been giving, is partly technical, and also providing the national sampling frame that the survey has always been undertaken. I think the last one was done in ASEP 5, which I think this is one of the major surveys that have been undertaken in it, and that should be really the end of that, the lifespan of that particular frame. We are actually currently developing another frame which has better features than what we have had before, and we believe that going forward would be able to support more of the this kind of activities of data generation, particularly those that are health related. And so we are really delighted about it. Now, one thing that I would really mention about malaria indicator survey. Way back in 2007, when we started the first one, there was the use of some technology which was just different from paper. That's the first time that personal data assistant, the PDAs, were used. And all the subsequent surveys or the series of malaria indicator survey have actually taken that step and progressively moved to the level where we are today. But particular interest that I'm drawing from that is that that is also the first time that as a Bureau of Statistics, we benefited from data collection that was somehow digital. And we picked it up from there and ensured that our surveys have now been taking that direction to the extent that we were able to conduct even a census which was fully digital. No wonder today we are still able now to support some of the health programs, because the tablets that we used in 2019 census, we are now giving them out to be used for monitoring of the COVID-19 vaccination process. I think either yesterday or if that did not happen, then today we are giving more of the tablets, 4,900 tablets to the ministry, after having given 1,100 earlier, so that we are able really to deal with our vaccination properly and to ensure that they are fully recorded. So that is courtesy of the process that somebody somewhere, when we were doing 2007 malaria indicator survey, came up with an idea, which we picked up and we have moved with it. So I'm really delighted about that, that as a country, we are making very, very good progress. Going forward, and in fact, in another front, this is not the end of the data that we are generating from the survey on malaria, indicator survey. But we are also now, we have taken a module in the forthcoming demographic and health survey, which we plan to undertake from the beginning of next year, so that we are still able to get more data that will be able to inform the policymakers more, because this one was done towards the end of 2020, and now the survey that will be done in 2022, somehow a span of 2 years, will still be able to give us more data. So we would progressively get more information that we need to continue using, and that would actually be very, very helpful to our nation. I do not really intend to say so much. Of course, there are a number of other programs that we are undertaking together with the ministry, but at this point in time, I would really thank all the institutions and organizations that have contributed to this activity, because it is not a very easy one to manage. Undertaking surveys are not very easy. And when we get to a point where we are now dealing with a launch, then it means that there have been a lot of efforts behind all that for us to achieve this kind of success. I would also finally thank the survey team. I remember the first time I was meeting Dr. Githuka, they came to my office with Madam Christine. Christine, I'm about to call you Christine Malaria, because it has been in your heart. So the first time actually I met Daktari was when we were planning for this survey, and that time there were a lot of restrictions, and we were not very sure if it was really possible to do it. So the long range passed by, and my colleague, Mr. West, mentioned that the survey was delayed. But they insisted that, can we get a window of doing this? We were looking at it and not seeing really the real possibility of undertaking the survey. But an idea came that, no, we can also use the short range to have it done. So Christy never gave chance. And Daktari, together with Christy, thank you so much, because if it were not for your insistence and trying to look for all the ways, we would not be here to celebrate the good results that we are seeing today. So could we have, yes, thank you so much. And with that, colleagues, I would really want to thank everybody and wish you a good health as we now use the data that we have. We are just going to get from this report to make our country a much better place to live in. Thank you all.
So you can see in front of us, we have the book here, 20 Malaria Indicator Survey Summary Report. It's now my pleasure to hand over copies of this report for reading, dissemination, but more importantly, for using the information contained therein to make informed decisions. Thank you very much.